Well, thank you, Sean. Thank you for that introduction and welcome, everyone. This is really uh, just a terrific, full, rich subject. I mean, there really is never been a time more exciting to be involved in treating the skin of color patient. And tonight we're going to talk about new treatments and options and protocols and guidelines. And really, the goal of this webinar is for you to have an increased understanding and comfort with the 650 microsecond technology and how it fits into your practice. So here we have the landscape. 1 in 4 skin of color patients want aesthetic treatments. And we know that this is a growing population. In fact, the fastest subtype of aesthetic patients are skin of color patients. So whether you know it or not, these patients are in your practices. And what we don't want to do is have to send them away and lose business because you don't feel comfortable with laser options. And as well, you don't want to create complications because you were unaware that you had a skin of color patient. I'm going to get to that a little bit more, but on this table, we can see that this population is estimated to grow to 50% by 2045. And when we look globally, skin of color makes up about 80% of the global population. In terms of what are the demands and what are people seeking, the number one skin problem in the world is hyperpigmentation. It really is a significant problem globally, both from medical aspect and also aesthetic aspects, followed by acne, melasma, PIH, hair removal, and pseudofolliculitis, barbae. So there are nuances in skin color, and all skin of color is not the same. And people within different ethnicities have different types of skin. So you can't really talk about, Latina skin or African American skin or Caucasian skin, because within these subtypes, there's a lot of differences. And increasingly, we're seeing mixed ethnicity. So mixed ethnicity leads to even new skin types. There are skin types evolving that we're not even aware of. So if you've ever heard me speak before, you may have seen this slide, and I say beware of the Oklahoma blonde. Okay? Now, whether you know it or not, the Oklahoma blonde may be part Native American, particularly the Cherokees are from Oklahoma. And it may not be so obvious. Here is a child with blonde hair, and she's very fair, and she's a child of a Native American mother. Now, you don't want to find out when you're treating this person for hyperpigmentation and scarring that they're, indeed, are a skin of color patient, because you chose laser settings for a Fitzpatrick 2 when their skin is behaving like a 4. So this is, I see, the area where we can really lead our specialty in understanding that these mixed ethnicities are really in our practices, and we have to be diligent in seeking them out. So, what are the properties of the skin of color? Well, we know there is delayed photoaging in our skin of color. And when we're talking about skin of color, we're talking about 4 through 6. So there's a delay in photoaging, anywhere from 10 to 15 years. And we also know that hyperpigmentation is more prevalent. And the melanocyte is very labile and very fragile. So it takes a minimal type of injury or inflammation, just a little burn from cooking, a scratch from the dog, can lead to hyperpigmentation. And the hyperpigmentation in skin of color is more prominent and more persistent. And just going back to, basic science here, just remember that it's not the melanocyte number that is increased in skin of color. It's the melanosomes, right? So the melanosomes are much more in skin of color than in light, and this is what's depicted there. It's the melanosomes, and it's also the way the melanosomes are aggregated. So when we look at skin pigmentation, and the more epidermal melanin you have, the more your melanosomes are larger. And there's an increase in the number and size. And with that goes the fact that you can also have an increased risk of pigmentation, either hyperpigmentation or hypopigmentation. A lot of times you forget about hypopigmentation, and we see hypopigmentation in skin of color a lot with, cryotherapy, liquid nitrogen therapy, a little bit with electrocautery when it's too deep, but it's frequently a complication of laser. And we see it a lot in especially hair removal laser, where the setting is too strong and you wind up with hypopigmentation. The other unique properties in skin of color is the healing properties. These fibroblasts in skin of color have exaggerated responses. So our normal repair process is kind of on steroids and can lead to these scars and also scarring and keloid formation. So treatment options really need to be at the top of mind to respect these qualities. So in 2008, I developed this scale. It's the Roberts Skin Type Classification Scale. And really, the capsule summary of it all is that let the patient's skin do the talking. We don't really care what the race is of the patient or the gender or the age or the ethnicity, because as I said, these emerging skin types with mixed ethnicities can really lead to unpredictable outcomes. So this scale really determines skin response. So I say let the skin do the talking. We're looking at skin response. And here is a summary of it. When you look at the table, you see 4 elements of the scale. And the 4 elements are Fitzpatrick, hyperpigmentation, glow-gal, and scarring. So we'll start off looking at the Fitzpatrick. We know that the Fitzpatrick scale measures the skin phototype. When the skin is burned and exposed to UVB, what happens? White skin always burns, never tans. Then the 2 is white skin always burns, minimally tans. I don't need to walk any of you on this call through this because everyone knows what the Fitzpatrick is. And we all, look at our patients and determine kind of what they are. Perhaps we really should be asking the questions about tanning, but oftentimes those questions aren't answered. So the second element is the hyperpigmentation, and this is measuring the propensity for pigmentation. So how do you know if a person has a propensity for pigmentation? Look at their skin is the answer. We have to look at their skin. So you can ask your patients, but you can also examine them and ask them, do they have any spots that are brown and pigmented and due to trauma that haven't gone away? That's the best way of getting the score. And this score starts with the H0, which is hypopigmentation, which I spoke about earlier. And then next is minimal and transient. By transient, we classify transient as hyperpigmentation under a year. And permanent is greater than a year. And this is pretty much globally accepted policies when we're talking about pigmentation. Then we have moderate and transient, moderate and permanent. And then our really tough patients are this last group of patients, H5 and H6. These people have severe hyperpigmentation, and the 5 is transient, and the 6 is permanent. The next element is the glow-gal scale. Dr. Richard Glogow developed this scale to describe photoaging. And this goes from a Glogow 1, which is no wrinkles, and the signs of early photoaging, lentigines, maybe some telangiectasias, and goes all the way to the Glogow 4, which is that face with severe photoaging, and it's basically like a sea of wrinkles. And we all know what that skin looks like. And also in that setting is usually, lentigines and other lesions of hyperpigmentation. Now, the last element is the scarring scale, and that describes the scar morphology. So again, we start with the S0, which is an atrophic scar, right? Because we have atrophic scars that are oftentimes caused by devices and lasers. And then we have our S1 as none, our macule, our plaque, right? And our keloid, and then the keloidal nodule, right? So those are the elements, and how we put it all together and make it come to life is all of these elements are separated by a slash. So an individual person would have a certain skin type. And this is the beauty of this is that this skin type can always stay with the person, and it can be communicated by text, phone. It can be written in the medical record. And when your patient transfers around or travels, whatever, they can have this skin type, and it really communicates to any physician who's doing a procedure on this person how their skin is going to perform. So let's just say in the previous slide I showed the Native American woman holding the fair blonde child. So let's say her skin type might be a Fitzpatrick 4, okay? Light brown skin, she burns minimally and tans well. A hyperpigmentation 2, when she has injury or insult to her skin, she gets minimal pigmentation, but permanent, okay, for greater than a year. So right there, you know that you've got to be careful because this person can hyperpigment, and it stays around for a long time. She's a Glogow 1. She's got no wrinkles, maybe some signs of early photoaging, and she's a scarer, right? So she can develop hypertrophic scars, basically scars within the boundary, right? Not keloidal, but a plaque that's raised, scar-like in nature within the boundary. So she develops hypertrophic scarring. And that lets us know that this person can have considerable risk, and we have to, proceed with caution. And again, the pigmentation and the scarring risks are all done from physical examination. So this is an article in the JDD, and it's also discussed more in the supplement that everyone has. Okay, so now we'll move off of that, and we're going to get more into the actual laser itself. And I just thought we needed a slide to kind of define the millisecond versus the microsecond. So, the microsecond is 1/1,000,000th of a second, okay? And so we're talking about, very, very fast times here. And the common modalities and limitations for treating skin of color, talking about the past, what could we do? Here's a listing of them, and I think we're all familiar with the limitations, but, topicals, hydroquinone, has its own, problems, rebound effect. Retinoids, people don't necessarily tolerate them. Tranexamic acid, we're just finding out about that. And, the data looks good, but we don't have enough really data here in the States on that yet. With peels, peels are effective for the epidermal pathology, but in skin of color, it's really can be risky to go down to the dermis. Although, there are practitioners that do peeling very well in skin of color and go deeper. I would say, somebody just coming out of residency or just getting started, or doesn't have a lot of experience, may not feel comfortable doing deep peels in skin of color. The light-based devices, the gold standard heretofore has been the long pulse neodymium YAG 1064. And that's a laser which is in the millisecond pulse width domain. And that presented a problem because it was not quick enough to not cause thermal injury. So even though the long pulse YAG did the job, there were always risks of thermal injury, pigmentation, and scarring, and conservative settings were, always required. Sometimes we had to do test sites, especially, on our darker skin types, and having to do conservative settings really sometimes lessened the efficacy because you couldn't go as aggressively as you might like for fear of side effects. And the other thing I want to talk about is really important is that a lot of patients seeking help for lesions were turned away because practitioners may not be familiar and comfortable with the laser. So as they should, not doing any harm, they tell patients, well, I can't do laser on you. Laser is not for darker skin. And so there's groups of patients that really could be treated but are turned away because of the unfamiliarity with the new technology. So I'm very excited about this because we can treat more people. In radio frequency, does a lot of the dermal things, but in terms of, pigment or PIH, those types of things, it doesn't really address. And it can be painful, and it can cause PIH if it's too strong. Microneedling, the limitation with microneedling, I love microneedling, and I do a ton of microneedling. But, on certain skin types, there's always the risk of PIH. And then there's always about efficacy. We're just really just starting in learning about our outcomes with microneedling. So we'll see with time how well microneedling works for these different disorders in skin of color. So now we're going to talk about the picosecond laser. So the picosecond is also a new laser, and it has a very high safety profile for skin of color compared to the traditional ND YAG 1064 long laser that we've talking about. And it's also below the thermal relaxation time, which I'm going to discuss in a moment. The problem with the pico, though, is it superheats the epidermal pigment, but it doesn't have enough power or a sufficient pulse width to break down the deeper dermal pigment. And that's why it's great for tattoos and some superficial lesions. But if you're dealing with things like melasma or postinflammatory hyperpigmentation, you need something that's going to be able to break up that deeper dermal pigment. The pico energy is less than 1 joule at a 850 picosecond versus a much more powerful pulse of 41 joules for the 650 microsecond. So a lot of difference in power with that. As well as reaching the pigment, I like to use my Neo for rosacea. And the pico, again, lacks that sufficient pulse width to be able to coagulate those deeper dermal vascular components and diffuse redness. Practicing in Palm Springs, I see a lot of patients with just kind of this diffuse redness that I really like to go after. It might not be quite rosacea yet, but they're the flushers and blushers. And I love the Neo for this because it's able to get those deeper vessels. And there's a ton of vascular conditions that require these higher fluences and longer pulse durations than the Pico. And then we see the quote here, and I know that everyone knows and is up to date that more and more we're seeing that increased vascularity is one of the major findings in melasma, as well as just the general breakdown of collagen and photo damage that we see in the dermis. So melasma treatment is evolving, and we need a modality that's going to treat all of these aspects of melasma. So our current challenges for our patients, I think this quote, this is from the supplement, which should be in everybody's mailbox. Well, it is in everybody's handout. And this is really sums it up. In skin of color patients, medical and aesthetic conditions have been treated with limited success. You know, we're good, we're better than we were, but we're not at the best yet. And we all know that light-based therapies have significant risks. So we as physicians, you know, in out there in the world, we're looking for that device, which is a go-to device that we can, you know, be the workhorse that can be safe and effective. And for me, I really need repeatability. I want a device that has repeatable results, and I don't have any surprises. And I think that all of us want that. We want to feel confident. And I put here, you know, for me, I want to feel as confident with the laser that I'm using in Skin of Color as I do with a can of liquid nitrogen on white skin, right? You pick it up, you do it, you don't have to look back, you don't have to worry about it. It's predictable. You can get the job done very quickly, and we do it all day long from room to room to room. Well, I want a laser that I can do that with. I definitely don't want to create a complication. And I like to treat all the conditions with one laser versus many. You know, at one point in my office, you know, it looks like a parking garage because you have so many lasers, you know, parked up next to each other, and, you know, using this one for this and this one for that. And again, that is not the most efficient way. I definitely want something with proven results. And maybe I'm fresh out of residency. I'm wanting to build a diverse skin of color practice in my community, and I really want something that I can, you know, have a go-to laser that I can use in diverse skin disorders. So this is really the breakthrough of the 650 microsecond technology, because this laser has been able to accomplish things that have not been accomplished before, such as no skin cooling necessary, right? The pulse duration, which we're going to talk about, because it's so short, 5 to 50 times shorter than the traditional long pulse laser, it permits this pain-free treatment where you don't need skin cooling or anesthetic. So right there, you're kind of saving money because you don't need your Zimmer chiller and you don't need your topical lidocaine to get the job done. The energy delivered with this 650 microsecond technology is a collimated beam. And that's really nice because it permits us to vary the handpiece to skin distance without altering the fluence. And that enhances efficacy and safety. And we'll see in a video later where you can see me just kind of, you know, going closer to the skin and back from the skin, and it really doesn't alter your outcome. So another quote from one of the key opinion leaders who did this supplement says that the 650 microsecond 1064 laser is more repeatable, safer, and less dependent on operator technique. And I would concur with that. This is a great laser for someone who is just getting started and really not experienced with laser because it's built-in safety. And let's look at this. The mechanism is this. The energy is delivered into the skin so quickly that it bypasses the epidermis without thermal injury and reaches the dermal structures, including hyperpigmentation. I talked about vessels, but also sebaceous glands. So it's very good for those. That's why I like it for rosacea, because it really does a nice job on the vessels and the sebaceous glands. It has a unique collimated beam, so you get enhanced efficacy, safety, and versatility. Kind of said this before in a little different way, but it's because it's collimated versus a focusing beam, it gets a deeper penetration. And the distance from the handpiece of skin doesn't matter, and the fluence remains fixed. So it's very user-friendly and not technique dependent. So this is really the slide which summarizes the 650 microsecond technology. Let's look to the right, and you see all of the different lasers lined up there. Well, you can see that the IPL is really the most superficial device. It's not really a laser, and it does not really penetrate deep, right? And we move along, we see the 532 and the pulse dye, the alexandrite, the diode, and then the long pulsed YAG 1064, okay? And then we see the NEO, the short pulse 1064. So when you look at this, you can really understand how it's important to be able to go deep, especially when you're dealing with disorders where you have deep pigment or vessels. And what you don't want is the collateral damage. So what do I mean by collateral damage? Collateral damage is when the pulse goes to the area, and the heat starts to spread into adjacent tissues and starts damaging areas that you don't want damaged. And that erythema is what can cause the post-inflammatory hyperpigmentation and scarring. So when you look at our graph on the left, we see on the x-axis, we see that we have our pulse width, and we see that the blue bar is the 650 microsecond. And it's shorter than the thermal relaxation time. So thermal relaxation time is defined as the time that 50 to 63% of the heat is dissipated. And that time is a golden window of opportunity. And if you can come in under the thermal relaxation time, then you're less likely to do damage. So what we see is that we can give very, very high pulses, up to 255 joules of power, and we give it in 650 microseconds, which is well below the thermal relaxation time of 800. And because of that, the fast, powerful pulse, that's why you don't have to use anesthesia and you don't have to cool, because your nerve endings are not affected by the heat. And it's the heat which affects the nerves, which is giving the pain. Okay? When we look to the right of that, we see the traditional YAG technology, and that typically has a pulse width of 1,000 up. And the longer the pulse width, which now is, again, in microseconds, the more apt you are to have that buildup of heat. And that's what's going to give you the complications of pain and hyperpigmentation and scarring. So, really, the 650 has the highest pulse power in the industry, and it's the ability to give that powerful pulse in a very fast time under the thermal relaxation time, which makes this able to achieve what it does. So I think that's really important to understand. And we don't need to numb, we don't need to cool, because these pulses are powerful and they're quick. So let's move on to looking at what some of our colleagues and key opinion leaders are saying about the 650 microsecond technology. This is Dr. Fran Cook Bolden, who did a beautiful article describing all of this, and it's in the Journal of Drugs and Dermatology. It was done in 2011, and basically that's what she says, that we don't have to numb, you don't have to cool the skin. And the other feature is that it's very sanitary, because the handpiece is not touching the skin, it hovers above it. You don't have to clean, after each patient. So you get effective results, and you don't have to, change handpiece, etc. So Dr. Gold likes this laser for pseudofolliculitis barbae. And he goes on to say that it benefits his PFB patients in 3 areas. The wavelength is very safe with dark skin types. The laser is compact, lightweight, only weighs, I think, like 20 pounds. And, you're able to, and it wheels, and you're able to kind of wheel it from room to room. Some people carry it if you have different offices. People have told me they've carried it to different offices. And it's just very easy to move around your office. And again, we talked about the pulse engineering for pain-free removal. This echoes Dr. Campbell Chambers. She did a lovely article in the JAD, Anti-Aging Medicine, for pseudofolliculitis barbae. And for her, it's her top desirable laser for treating that. Permanent hair reduction. So, using this for PFB, there's also a wonderful benefit, because you can use this for permanent hair reduction. So in this study from the Journal of Global Dermatology, this looked at 298 subjects who were treated with the 650 microsecond 1064, and 85% were satisfied or highly satisfied with their results. So it's definitely a safe laser. Here in California, hair removal laser is probably the #1 complication that we see in the aesthetic realm, and this certainly, using this laser, really will decrease those numbers. So here's a supplement, and this supplement is wonderful because it's practical, and it has what everyone's using. So you're really able to, take this supplement and really use it as a guide. One of the lovely things about the Neo is that it does have this collimated beam, and it can be used as a monotherapy or in combination with other therapies. So I do a lot of combination therapies with this, and typically when you're doing combination therapies with this laser, you do the Neo first, and then you do your other modalities. We'll look at this a little bit later, but I use it to treat melasma, acne, PIH, PFB, Acne, Keloidalis, Nuchae, just photo aging, and a lot. We're just discovering, all of the uses. And actually, that's why this supplement of expert clinical, people came to this, because we all had our uses for the Neo, and it all came together for this April JDD supplement. And I would say that, having heard all of the practices from all of these really, physicians and dermatologists with these rich clinical experiences, I would say that without a doubt, there is a new paradigm, there is a new gold standard, and the new gold standard for treating skin of color is this 650 microsecond technology. And it's a definite paradigm shift away from the traditional 1064 long pulse YAG. And, thus this webinar, because this really is the gold standard for treating skin of color now. So here are some of the highlights from the physicians who participated in this roundtable. Dr. Chilakuri has a very huge, diverse practice in Houston, Texas, and he gave his treatment protocol for melasma. He starts with hydroquinone. He does under 6% and non-hydroquinone, blending products at home. So he starts them off on that. Then he follows with the Gesner and salicylic acid peels and microdermabrasion. He alternated those. And then he does several treatments with the Neo. He does these treatments about 3 to 4 weeks apart. And his statement is just spot on. With melasma, we're targeting different aspects: the epidermal pigment, dermal pigment, upper dermal pigment, lower dermal pigment, vasculature, and I would say collagen, right? Photodamaged collagen. So the peels treat the epidermal melanin, but not so much deeper. Lasers can break up epidermal pigment, but with the microsecond technology, we're more specific to that. We're able to do the dermal melanin and vasculature that the peels cannot treat. So versus having to, before this laser came out, I would, have to pull out maybe 3 lasers to treat my melasma patients. If I was even going to do a laser treatment, I'd have to, pull out 3 different lasers, each one for a different component. But now we're able to do it all with one laser, which makes us more efficient. Okay, this is a patient who, as you can see, has some perioral pigmentation. And this is her before and after. She had 4 treatments, and these were done. These are photos of courtesy of Doctors Johnson and Cruz. And, these fluences were used about 21 to 41, and these 4 sessions were done. And then they combined it with this Perfect 10 peel, which is basically a kind of glutathione, kojic type of peel, and then used after the laser. So I think her results are impressive. And again, what I like a lot about the Neo is that I don't have to stop what I'm doing for melasma. This is an addition, and it's getting people clear quicker. So very nice result using combination modalities with the Neo. So this is a 66-year-old female patient of mine who had very brittle melasma. I mean, I did everything with her: chemical peel, microdermabrasion, nothing would work. So throughout a 10-year span, she continued to worsen. And just a reminder, when you're dealing with melasma, always check the medications and make sure that the patients aren't on any photosensitizers. So these are my settings, and I was able to get a very nice result with that. I mean, when you look at her zygoma, that's really significant clearing of the pigment. And she was one of my early patients with this technology, and I really became a believer because this was just after one treatment. Really nice. And what you can also see in this picture is that not only is the hyperpigmentation improved, look at the texture of her skin. Her skin just looks in better condition, right? And we all know what that means. Her skin looks fresher, it looks a little tighter, it just looks healthier. Dr. Saidi from Philadelphia gave some of her tips for acne. She likes to use this to treat PIH. So she uses the Neo, and she pre-treats with tretinoin before and after. She says she loves it for treating PIH. And the nice part is you get 2 for 1, because if you do have some active acne, you can treat the active acne as well as the residual PIH. And she sees, and I would concur, reduced pigmentation and erythema for the active acne lesions, reduced erythema after one treatment. And that's nice because, we've all been there where the patients after laser say, I don't see any results. So I love it that with this first treatment, especially with acne, people see results and they come back. So it's a super, super laser for acne. Here's another patient from Dr. Goldberg, and the slide speaks for itself. She did not want to take oral retinoids, and she had 4 treatments of the Neo, and here she is before and after. And again, if you look at the area where there's not PIH, and you see a really improvement in the skin texture overall. And that is, I call it like the little aha, special surprise, is that when you're using the Neo, you're going to treat the whole face globally. Okay, so you'll treat the whole face, and then you'll go and kind of hit the areas, of hyperpigmentation, obviously, that you want to get rid of. And what that leads to is an overall improvement in the texture. Look at her pores are closed. Her skin is brighter. And in addition, she's got this resolution of these areas of hyperpigmentation. And this is a benefit that your patients absolutely do notice. And it's a bonus for them because not only they get rid of the dark spots, they actually have the better, healthier skin and younger looking skin. So here is someone with, inflammatory acne, and I think we have a nodulocystic acne case in here, but we're finding out that this technology does very well with inflammatory acne and nodulocystic acne. This is a patient of Dr. Henry, and this is a Fitzpatrick 6, and you can see her before and after kind of speaks for itself. She had 3 treatments, and we see a significant reduction in her active acne as well as her PIH. So exciting results. And Dr. Henry shared her protocol. She starts with the Neo weekly to clear her cystic acne. So she's really kind of leading the way in using this in cystic acne, and she's got very impressive results. So I've actually started using it in cystic acne, and I'm impressed as well. So she starts doing it weekly, then bi-weekly, then monthly, kind of weaning them off. The patients are happy with rapid clearance, then combination topicals, and then a later treatment for any residual PIH and scarring. And she says that she's very impressed, especially with the nodules. So this is kind of the next frontier for acne with this. And I think we have a before and after. And here here is a before and after Dr. Awudu of this, cystic acne and clearing up. And this was after 2 treatments to the area. So again, real strides in acne for skin of color. Here we have another case from Dr. Gold of acne keloidalis nuchae, and we see marked resolution of these papules. The patient had 5 laser treatments at 4-week intervals, and just 1 pass, and significant improvement. So I think these early cases of acne keloidalis nuchae, this is a home run and can save a lot of debilitating surgeries, et cetera, that we have to do to treat this. So now let's talk about PFB a little bit. And Dr. Campbell Chambers says that in her practice, the Neo is revolutionary for PFB. And ironically, she sees more females than men who come into her practice for that. And I would say that as well. In terms of practice building, this is a population, a subset of patients really which have been invisible. Women tend to hide their PFB under thick concealer and not discuss it. So this is a real opportunity to grow your practice, to start looking at the chins of our female patients, especially our female patients, skin of color patients. There is a little higher incidence of PFB in the skin of color female than the Caucasian female. So, just start looking, and, you'll be able to offer this treatment. And your female patients are so grateful that, one, you noted it, you brought it to their attention, and then you've got a way to treat it. So I highly recommend looking for this, because this is really a home run, and you can get this chin area completely smooth and bump free and pigment free. Here are some cases. This is from Dr. Henry, before and after 3 treatments. Here is a beautiful case from Tesoro, and you can see the resolution of the hair when you look up to the cheek. The hair is gone, and the PFB on the chin, and if you look down to the neck, the PFB on the neck area is also gone. So, really nice results right under here to here, resolved, and then this looks really nice. And similar to the other results, you can see there's just an increase of youthfulness to the skin and texture. There's these textural changes that happen from, collagen remodeling that really makes the skin look younger and healthier. Here we have a significant clearance of PFB. Just always remember, when you're treating PFB, you have to, warn the patient that the hair removal could be permanent. So if they want to, grow a beard or wear a shadow, this may not be the treatment for them. I find most of my patients with PFB are willing to forego the beard and the shadow for having skin that looks like this patient. This is a patient of Dr. Hepburn, and this patient is very happy, after 3 treatments, and probably, does not care that he cannot grow hair there anymore. But I do recommend everybody asking. Dr. Burgess likes to use, this is her to-go-to laser for PIH, and, patients who have come in to her from burns, which we spoke about earlier, from, hair removal and PIH due to other trauma. She has a protocol where she uses the Neo, and she uses it in combination with chemical peels, and she's able to get rid of the PIH. So here are some examples of this. This is a female with major, acne scarring on the right cheek and PIH. She had, I think this is after her first treatment. No, she had 2 treatments and was able to obtain this result. So this is pretty impressive. 2 treatments with the Neo, and this area is really completely resolved. We see a little bit of a footprint here, but this area is resolved, both the scarring and pigmentation. And again, look at the texture of her skin in this area compared to here. It's just a smoother, nicer texture. Look at the pores here versus here. So again, when you're doing this, you're going to be treating globally and then focusing on the lesion. Next case, this is something you never want to see. And really, for the record, IPL should never be used in an African American patient, okay? There are lots of great studies in IPL in the Asian literature, and great studies, and IPL has worked really well in the Asian skin types. But for an African American, we don't completely know why. Perhaps it's just a lot of energy which is focused on the epidermis, and earlier we saw that the focus of the IPL is really on the epidermis, and this really disrupts the pigment and can cause a lot of PIH and scarring. So this is a patient of Dr. Burgess's, and when she used the Neo in combination with hydroquinone and some Jesners, and got this result, which is pretty remarkable for this type of lesion. And so just remember that you can use this, the Neo, for PIH following any kind of burn, especially an IPL burn. So for rejuvenation, you do 2 to 4 passes, and you can do more passes over darker areas. And the 650 microsecond promotes this collagenesis. So you get new healthy collagen, improves the pigmentation and the vascularity. And I like it because, before then I would use the fractional laser, but the fractional lasers are painful. And I also had to prep people with topical lidocaine before the fractional laser. So this I'm able to do quicker and with less discomfort. And let's move to the next. Keep going. So here's some skin rejuvenation and acne scar revision. This is the Neo was used in combination with microdermabrasion to get a really great result for those ice pick acne scarring. This is from Dr. Cook Bolden. This is a patient of mine. Used her for skin rejuvenation. Again, just better looking quality of skin. This is another African American patient who I used just for global. She just wanted a fresher look, and that's what she came in to tell me. She says, I just want to look fresher. I don't really, have any, lines or wrinkles, typically the case for African American women, but just like a fresher look, removing, some excess background pigmentation that she had in her skin, and just a little nicer look. I also did inject her lips, if you're noticing. So she had a little lip filler in that session. So, which brings me to the fact that you can use the Neo not only in combination with other things that you're doing. I've used it with microneedling, with microdermabrasion, but you can also use it on the same day with your fillers and toxins, which is what she had. She had lip filler that day. Okay, so let's look at a video. Here I have it's an African American female, Fitzpatrick 5, who I'm doing the procedure. So you can see, this handpiece is light. It's fits right in the hand, and she had pretty significant PFB, and I just love this procedure for females because this is an area she was very ashamed about. Make sure that the patients don't pluck the hairs like traditional hair removal laser. They can shave, but you like to kind of see the little hair coming through the ostia. And I'm just, going over the area. You see the collimated light, and we're up close here. You can see she's not flinching. She's very comfortable. There's no cooling that's needed. But I think everyone here can see that it's a very, easy, quick procedure. There's no need to overlap. So you can do your passes, whatever you're doing, 2, 5, 6 passes. You can do those passes without overlapping. For areas that have, increased pathology, be it pigmentation or an inflammatory lesion, whatever it is you're treating, you can go over that area more than once. And then if your patient is comfortable and doing really well, you can actually increase your power and do that within the same session. So it's not infrequently, once I started a lower fluence and lower mode and people are comfortable, then I can raise them up in the same session. Okay, I think that's the device that we talked about is portable, and it's just super simple. You can just wheel it right around your practice. Okay, I'll go to the next slide. So who can benefit? Dr. Burgess says that she doesn't think it should be pigeonholed for skin of color. It's a laser for all skin types. And I would agree with that. I use it in all my patients, Again, I'm in an area where the majority of my patients are not skin of color patients. I have lots of skin of color patients who come to see me from other parts of Southern California, but my indigenous population is not skin of color, and I use the laser all day long. But if you have a multi-ethnic demographic, it's definitely the laser for you. And if you're, building a skin of color practice, it's the laser for you. And then don't forget that we talked about those skin of color patients that don't look like they're skin of color patients. And, those, they're in your practice. And unless you, take a history, which I recommend you do, and when you're doing your skin type classification, get the history, get the ancestry, take a look at your patient, look over their skin, and skin type them, so you can really, predict their settings and safety with more accuracy. Dr. Rusha Campbell says anyone can benefit from this device. It's portable, it's safe, it's effective, it's a no-brainer. And Dr. Chilkuri says that it's the power of a larger device in a compact application. And I like that because it is, we don't have a dinosaur anymore. We have a little cute little, toy poodle to do our great work for us. It has a lot of science behind it. And also the laser company partners very well with you and, provides all the support that you need when you're getting started. So, some closing thoughts, and this is from the JDD article that I know everyone's just going to love. It's very practical and just gives you our settings and can really get you started out with confidence. You know, cooling and numbing can increase the risk of complications, right? Because we need our patients' feedback on numbing and cooling. You know, that's too hot. Okay, back it off. And if our patients are numb and not giving us feedback, we can often overtreat them. So that's what's really nice about this device is that your patients are feeling it in real time, and you're able to adjust, parameters. As I said before, if it's too much, you can back it off. But if your patients are comfortable, you can increase your levels, and this really leads to increased safety. Dr. Henry, her experience is that patients appreciate the time savings because, we all know that we have patients sitting around the office for, anywhere from 20 minutes to 45 minutes with, numbing cream on. So this is quicker. Patients don't have to numb, and your patients. Actually, I've had patients like jump up and down and say, "Oh my God, it's so great! I don't have to numb anymore." And we like that, and it's great for the office because you're able to see more patients quicker and get more patients through if you don't have people numbing holding up your rooms. So that's really a strong selling point for the laser. Dr. Henry thought so. The 650 microsecond pulse duration, the decreased thermal damage to the surrounding tissues, the lack of scarring, and the lack of pigmentary changes are all due because this 650 microsecond pulse duration is shorter than the thermal relaxation time of the therapeutic target. So we're able to get this power in a short, powerful pulse, which doesn't lead to the thermal damage. And when we can alleviate thermal damage, then there's no need for pain relievers as topicals, and it really eliminates PIH. So the options of the things that we've used it on are acne, melasma, PIH, psoriasis, rejuvenation. Some other things are elbows and knees, the pigmentation that you see on the elbows and knees. Again, in the sun belt, when people have their arms exposed, this is really requested. People don't like to see their hyperpigmented elbows and knees. So the Neo is great for this and, clears this up. We have some cases, we didn't show it here, but we have some cases of onychomycosis that have been cleared with this technology, and we can give you references. There are, published articles which talk about, onychomycosis. So, I would say there is definitely a paradigm shift. And now, finally, we have a true go-to laser for treating skin of color. We can be confident. We have repeatable results. We have efficacy. We have safety. We have a new gold standard for skin of color. And I guess we'll open it up to questions now. And I thank everyone for your time.
All right, thank you, Dr. Roberts. That was awesome. All right, so we have certainly gone over the typical hour limit that we have, but there's so much to cover, so much to talk about, and I think that's fantastic. So, again, if anyone has any questions, there is the chat box you can type into, and there is also the question box to type into. So if you have any questions, please type them in, and we will try to get to as many as possible. I want to start off with one topic that's come up a lot, and it is with PIH. When you're treating either acne or PIH in patients, I mean, what's more important? Do you need to get the acne under control, or do you need to get the PIH under control first?
Well, that's a great question. I always talk about acne in the past, present, and future. So when we're treating acne, we're treating all stages of the lesion, the past lesion, the present, and the future. And do them all. You're treating all of it. And with the Neo, you're able to do it all. You're able to treat the past lesion, the PIH, the present lesion, the active acne, and the groundwork, the area where future lesions will arise from. And I really was not able to do that with any of the other, earlier modalities. Is treat all those lesions. And with one device, you can do past, present, future lesions, and you add on, some antibiotics or whatever, topical preparations, and you've got a really strong acne regimen.
Okay, excellent. This one was asked by a doctor over in Nigeria. I know we haven't covered it too much, and I'm not overly familiar with it, but exogenous ochronosis.
Oh, yes, that's a great question. We have no experience really with it here, documented experience with exogenous ochronosis, but because of the rejuvenation and the neocollagenesis that occurs, I would definitely try it. Again, you won't do any harm with those patients, and there may be actually some efficacy. So I hope you use it and you can report back to us of how it went. But it definitely would be in my toolbox if I was treating ochronosis.
Okay. One of the things that comes up a lot is when you're using in combination, or if you have someone on a tretinoin or retinoid or something like that, do you need to stop any of this before laser treatment, or are you able to treat right through?
Yeah, that's a great question. Well, we discussed this at the round table. Dr. Saidi does not stop her retinoids. She does her Neo. She has the patients on the retinoids, and she doesn't stop. Okay? And my skin of color patients, I do stop. I just stop 2 to 3 days before, just because I'm a little bit nervous Nelly, and I just don't want to have any problems. But she never stops her retinoids, and she's had no problems. So I really think, it's whatever you feel comfortable with. I would, always, go on the conservative side and, take a patient off of them. I don't think it has to be a week, but, 1 to 2 days would be fine. And we have patients get off of retinoids, hydroquinone, and everything except like basic cleanser and sunblock before their procedures.
Mm-hmm. Okay. No, I think that's good to be risk averse in general. I know that there's a lot of studies going out there now and a lot of people looking into it, but that's great to know. One of the biggest treatments we see, obviously, hair removal and PFB. There's one picture with the gentleman by Michelle Henry who had PFB, and he kept his beard. Are there any treatment settings to kind of make sure of that, or what is a pro tip that you can give us?
Okay, so if someone really wants to keep their beard, I would just do very low settings. And the permanent hair removal is done with not in one session, so it takes multiple sessions. So I would do very low fluence. I would do very low settings and monitor the hair growth, because if you're seeing the patient back, let's say every 4 weeks, you'll be able to monitor. Now, the key with hair removal laser is that you don't want the hair to recover from the assault, okay? So in the old days, it would be, see your patient back in 8 weeks, right, to do your second session of hair removal laser. But you don't want to do that, because then the hair, the bulb, has time to recover. Basically you're assaulting the hair follicle. And you don't want a recovery. You want to hit that hair, as much as you can, every 2 to 4 weeks, 4 weeks tops, because that's how you're going to affect permanent hair removal. So some of the failures in permanent hair removal is because it's been too long that the hair is able to recover. So in that case, I would, where you want to keep the hair, I wouldn't do it every 2 weeks, because if you do it every 2 weeks, you're probably going to, permanently remove that hair. I would do it every 4 weeks. It would take longer to achieve the results, but the patient will probably be able to keep most of his beard hair.
Okay, excellent. Dr. Bev Johnson just said that she'll also start Accutane and Neo treatments together sometimes. I don't know if you've ever considered that or have experience with that.
Well, hello, Dr. Johnson. No, but I have heard that. I've heard that, and people have done that very successfully.
Okay, I just had to give her a little shout out there.
Yeah, I know. I know, me too. I would just say one thing. There is increasing body of evidence that this waiting, months and months to do anything after Accutane is being refuted. Again, I think the way we'll all be practicing is not so scared of Accutane and starting treatments a little bit earlier than we had in the past. So I think she's right on with that.
No, absolutely. Here's an interesting one. Pilonidal cysts. Any experience with treating those with the laser?
No, and I love that question. I don't, and I haven't heard of it, but it's certainly, again, with the safety profile of this laser, try it. You can do no harm.
Fair enough.
And it does effective, hair removal, so I would definitely try it.
Yeah, we do have a customer in upstate New York who I believe is experiencing with that, and he's having some pretty good results. Now, one of the biggest questions we are getting right now is on melasma. Would you be able to share we went over obviously what the basic guidelines are for treating melasma, but what are you having the most success in, and what real treatment pearls can you give us for treating melasma, especially some really hard cases?
Yes, I do have a good number of brittle melasma cases. So I like a combination treatment for melasma. I start with a series of microdermabrasions because I want to remove any, epidermal pigment hanging around superficially. So I'll start with that. And then I like to use and this is on the same day. So we'll do like a nice microdermabrasion, and then right there. Okay, important. If you have a crystal microdermabrasion device, you've got to clean the face off of crystals. Okay, but if you have a diamond tome or something, then you're fine. You don't have to clean the face. Then I go right then and do the Neo, and I do it globally. I treat the whole face, right? Because remember, we want to improve the quality of the collagen, right? So I'm doing the whole face for the collagen, the deep collagen remodeling, not for the pigmentation. Then, and also the vascular component, right? Then I go to the actual lesions and do, multiple passes on the lesions. My first treatment for melasma is always a little bit more conservative, but I use the 6 millimeter, lens, and I do my pulse widths about 0.65. When I get more comfortable, I go up to 1.25. I stay in the 6 mode. I stay on the 4 mode, and then gradually with each treatment get more aggressive. So after I do the Neo treatment, what I have been starting to do is using like short contact, bleaching agents, and putting them on the skin right there, and having the person kind of, hang out for 15 to 20 minutes, and then remove them, put sunblock on them, and see them back in 2 to 4 weeks. So this is working really well. I tend to not use peels anymore for melasma. I've really gone to the microdermabrasion and the neo. So I see that as the biggest change in my treatment is I have kind of not had to use, the peels anymore. But the microdermabrasion, the neo, and then the topical. I'd also put in a plug for, especially if you're living in the Sun Belt, HelioCare. You'd be amazed just putting on a patient on HelioCare how much it can reduce the pigmentation. So have them on that, and have them on a good physical sunscreen. And if you have sports enthusiasts, I have my golf ladies wear makeup in golf, because most of the time people take off their makeup to do sporting events, outside activities. But in the case of melasma, you want to put on makeup and go out and do your activities because it's just another layer of sun protection. And you can start low with these. Let's just say, if you're going to do 3 treatments, your first session should be conservative. But if the patient's tolerated fine, no side effects, then pump it up the next session, your second session. You can, really proceed a little more aggressively. And that's what I really like about the Neo is that, I've been, very aggressive in some cases because, some of that pigment is deep and, you need to break it up. So you have to be a little more aggressive.
Okay, thank you so much for that. Like I said, that was a big question that was coming through. So I'm going to take just one more. I'm going to do a little multi-part question, but just in terms of everyone's time, we'll try to wrap this up. One thing I wanted to ask you was, so we had to talk about a lot of different treatments. Are there other treatments that you're excited to try this for? And, what do you think this might be used for? I had a couple of people ask about hidradenitis suppurativa. I had a couple people talk about overuse of hydroquinone and if it can reverse those effects, and even rosacea in Asian skin. Can you talk about what you're for? Yeah.
I'm very excited about it. I mean, one of the things that I'm really doing a lot looking at is acne scarring, not just, acne and PIH, but acne scarring. So getting some nice results in acne scarring. Definitely hidradenitis. I think there's a role for this because, we're seeing the great results that Dr. Campbell and Dr. Henry are having with the nodulocystic acne. I had a couple of nodulocystic acne patients that have also had great results. So I think that this really could be a possible treatment in the treatment box for hidradenitis, and would definitely do this with a hidradenitis patient. Again, you've got nothing to lose. The 1064 goes deep. And I really am excited about this for hidradenitis. I use it a lot in rosacea. Rosacea in Asian skin is perfect device for that. Again, start low, conservative, treat the whole face, and I can't overemphasize that. Treat the whole face first, and then go to those areas. It's kind of reverse of what we've been, have done for other things where you just treat the area affected and you leave everything else alone. But you want to treat the whole face in all of these. What was the other, Sean? There was another.
Yeah, we had an interesting one about someone who had overuse of hydroquinone under their eye.
Yeah. Great. Overuse of hydroquinone. Again, I think this could do nothing but benefit those people. I've had some amazing, tough cases of pigmentation that I, have used this in. And remember, a lot of times your melasma cases have a component of, hydroquinone overuse in them. You know, those darker areas of pigment that are speckled between the lighter areas, patches. Some of that is due to hydroquinone overuse. So in that case, I would I would not, of course, use any hydroquinone products, but I would do a lot of microdermabrasion because microdermabrasion leads to collagen remodeling too. So studies are showing now that microdermabrasion isn't just a superficial, that it does collagen remodeling happens with microdermabrasion, and that's why I think it's so synergistic with the Neo, because the two are working together, so you get even enhanced dermal collagen remodeling, and can be great for rosacea and melasma.
All right, awesome. And just again, as you were talking about that, we had a couple of people come through, and we have different customers. We have Dr. O.C. Wudu. To your point about the atrophic acne scars, he's using it with microneedling as well, having some great things to say. We had Dr. Johnson talk about gram-negative folliculitis, and also Maggie Rupp on Long Island, granuloma annulare.
Oh,
so a lot of different.
That's great. I mean, Sean, we're calling it the to-go-to laser for, skin of color, but it might be the to-go-to laser, for the house of dermatology. I mean,
yeah, it's interesting, but it's
right.
I mean,
the things that we're hearing, it just gets better and better. So it's such an exciting time, to be in and to have this kind of technology.
No, it really is, and I really appreciate you sparking this conversation for everyone here. All right, so again, we're running towards the 9:30 mark Eastern Time, so we're going to wrap this up. Again, if we haven't gotten to your questions, we'll follow up afterwards with you. But really appreciate everyone joining us, and Dr. Roberts, thank you so much. We're going to have some campaigns, some other talks at various trade shows. But thank you so much for helping us out with this.
Oh, you're welcome, and everybody have a great evening and a nice holiday.
All right, thank you very much. Everyone, have a great night.
Bye-bye.